Welcome back to this week's edition of Freedom and Prosperity Radio, the weekly radio news magazine we'll put together here at the Virginia Institute for Public Policy. Find out more about us at virginiainstitute.org. And, of course, our YouTube channel, where we archive all these visits and discussions online at YouTube, and search Freedom and Prosperity Radio. Up next, the Director of Policy for Tertium Quids, Caleb Taylor. He's also the Director of Policy for the Virginia Institute of Public Policy, and working very closely with the Healthcare Freedom Initiative. He's going to catch us up on where we stand with that, especially in times like these and other overused expressions. Good morning, Caleb. How are you doing, sir?
I'm wonderful. Thank you for having me again.
Not at all. And the Healthcare Freedom Initiative, is something that has been born sort of through a lot of the folks, and people, wonder sometimes of the power of the Virginia Institute for Public Policy. And we have, as an organization, and I just say it in the royal we, you guys let me hang around with you at the cool kids table, have gotten a lot of legislation through the Virginia General Assembly, up to and not limited to constitutional amendments. And much of it is because of the coalitions we build and the partnerships we develop. Tell us about this Healthcare Freedom Initiative, and where is it right now?
Well, the Healthcare Freedom Initiative started several years ago after the vote to expand Medicaid in the state of Virginia, which, we were kind of universally against, but it happened, and there's not a whole lot we can do about that. I mean, we can complain about it, but it's what it is. From that point, we started looking at, kind of trying to answer the question of where do we go now? And I think the number one part of that conversation, or the thing that really kind of changed our focus, was we stopped talking about how do we pay for this now, and started talking about how do we address supply issues that are part of what's making it so expensive. And so we started really, really focusing on kind of the supply side of healthcare, and that's what started it. And this was years ago now. We started looking into lots and lots of different innovations. One of the big ones being telehealth. The interesting thing is that. And this is from just reading loads of code, not just for Virginia, for numerous states, but reading loads of just legislative code and seeing that our healthcare code is actually written from the perspective that everything is illegal until we make it legal.
Gee, that's a great way to look at things.
Yeah, not exactly what you want to see in a free society.
No.
But we were able to kind of go through this and identify some very specific things that needed to change so that we could start kind of addressing these supply concerns. One of those being kind of that rhetorical direction of the law. So with telemedicine and all the different little pieces of telemedicine, telehealth, we started to really kind of open the doors little by little. And now, when I say we, I mean like our coalition as a whole. The Virginia Institute doesn't do any kind of lobbying or anything along those lines. What we do is we build models, we build research and models, and then we give it to different people in our coalition to say, hey, we think this is a good idea. Why don't you guys run with it? And then they do, and we've been very, very successful in that. In fact, at this point, I'd have to say that about a half to two-thirds of the telemedicine code in the Virginia State Code I've written.
This is what I'm telling you, folks. Yeah, this is there.
But we're working in a really positive direction. We've opened the door to things. We've opened the door not just to kind of the generalized idea of telehealth in the legislature. We've opened the door to a lot of different conversations, from cross-border licensure acceptance, which has been something that's had to grow year over year because it started off at when we first started talking to people about it, they looked at us like, what? But things like remote patient monitoring, which is the ability for your doctor to monitor your physiological data from your home. Previous to this year, the only patients that were permitted to use it were diabetes type 1 and diabetes type 2, and only do glucose levels. They couldn't do anything else.
Check your heart rate or anything like that. Wow.
That's right. So we actually have there's a bill that's being supported by the coalition members right now that will actually expand that considerably, and also deals with Medicaid reimbursement on that. And we're kind of excited about it, kind of getting through. It looks like it just passed yesterday. I believe it was yesterday. It just passed through subcommittee unanimously. Mm-hmm. So we're very excited about some of these great changes to the healthcare supply in the state. So.
Well, and we just watched in the waning days of the Trump administration, the Department of Health and Human Services, started a pilot program with a lot of Virginia hospital or a lot of nationwide hospitals, and one of them being the University of Virginia Medical Center, to expand on their telehealth there. And one would like to think that it's just in the best interest of the hospitals to expand their reach where they can. But as COVID-19, and I hate to use the phrase upside, but because of what the restrictions on interactions have become under COVID-19, has that sort of made the case for telehealth expansion?
I mean, it really has. The really, really amusing thing was, several years ago, we created, when we first started the telehealth section of this conversation, we created a list of priorities of things that needed to change. Mm-hmm. And when COVID hit early last year, about I think April or May, several of the governors, including ours, and the president, essentially adopted all of our entire priority list as their waiver
position
idea.
And
so they created waivers for essentially our entire list. And so right now we're kind of going through and seeing, what are these things that are worth keeping and not going back on after COVID's done with. But yeah, I mean, COVID, I agree. It's hard to say upside, but this pandemic has really created an opportunity to see the real value in some of these innovations. And I'm very, very excited. I mean, it's gotten so far now that we're hearing whispers and chattering that, Amazon's going to leverage this into an Amazon healthcare.
That wouldn't surprise me at all if Google isn't thinking of doing the same thing. I mean,
Amazon gives me my packages so quickly. I would be just fine with them taking care of that too.
What does I just thought of something though. If Amazon does this, obviously as trafficking it, does that open up a lot of privacy issues with healthcare providers? Talk about telehealth and privacy, Caleb, and how you guys have been able to address that in this code.
Well, it's actually really very simple, since because telehealth is defined as an actual medical service, it still comes under HIPAA. Now, I'm not a huge fan of the way that HIPAA is handled today. I'd love for that to change, but it still kind of comes under that ideal. And what we see is these telehealth organizations, kind of driven by websites, kind of driven on the internet. They end up being they just naturally via just the market, they naturally end up being highly secure because these organizations know, the telehealth companies in specific understand that the number one thing that they cannot survive is a data breach. It's not like a bank where, Wells Fargo has a massive data breach and it kind of hits the internet and then people are angry for about 3 weeks. No, with a healthcare company, some patient somewhere has a data breach and suddenly their entire family and everyone they know found out that they caught herpes 3 years ago. That becomes a massive problem. Mm-hmm. So these organizations naturally, via the market, recognize how important it is to maintain privacy inside their holdings, and they end up being highly secure. Now, of course, there is some protective language to make sure that patients are protected, but it's not. We try to keep it as unburdensome as possible, while at the same time maintaining as high a level of privacy protection as we can.
Caleb Taylor,
so these organizations are not like Facebook. They're not in the business of selling people's information to make money. They're making money directly off of the services, just like a doctor would.
Transactional. Caleb Taylor is Director of Policy with Tertium, Quids, and the Virginia Institute for Public Policy. We're talking about the Healthcare Freedom Initiative. I had asked you that mainly, about the privacy issue, because I know that it is an impediment to a lot of folks who, would otherwise be able to access a lot more medical care in rural communities. We heard during the Obamacare discussions that the old country doctor has gone the way of the dodo, and in many cases it's because of insurance premiums and the cost of running an office becomes so much that doctors have to partner up, and you'll find the one office with 8 or 9 doctors in it, and it helps them ease up on some of the insurance burdens. How does that hit the telehealth industry? What is it still maybe before insurance? Don't tell anyone before they've caught on to what's going on here?
Well, that's actually the really interesting thing. Is we've been talking about leveraging telehealth for rural communities for years now. And interestingly, one of the major concerns among legislatures and other stakeholders was a lot of these rural communities don't have good enough internet to handle that. And the great thing is we've started to see even that, partially because of the growth of telehealth, especially through COVID, we've started to see things change about the way that broadband and internet are planning to expand. I'm not sure if you're familiar with it, but just recently, maybe last week, the FCC changed their OTARD rules. Are you familiar with the OTARD rules?
I know the story, and we covered it briefly, and yeah. I'm trying to remember the specifics of it, but please go ahead.
Well, OTARD was originally created to essentially protect small satellite dishes during the satellite wars back in the 90s and 80s. Satellite dishes from local regulation, so that people could have their satellite TVs and stuff.
Right.
And what the FCC did last week was they expanded that protection to personal internet antennas, which are very small. Yes. They essentially so it operates the same way as your standard monstrous internet tower, but it's in a much smaller size. It essentially it's a small antenna that you can attach to a tree or attach to your soffit or something along those lines. And they had not been protected, and a lot of even homeowners associations were outlawing them. We don't want to see these around the neighborhood kind of thing. Mm-hmm. Well, the FCC said, no, you can't do that anymore.
Oh, that's a great. Because we've even seen in areas of the rural central Virginia where the country store will set up a tower off of their roof, with a Wi-Fi needle on it, just to create some internet access for their neighbors, and then everyone kind of chips in. I always thought it was a neat free market way of dealing with it, rather than waiting for the government to whip a little broadband on you.
I think that was a great idea too, and apparently some people up at the FCC thought it was too. So now anybody can do that. So I see some pretty dramatic expansion of internet into rural areas in the next 3 to 5 years, and that kind of goes right alongside of the expansion of things like telehealth. Among other innovations, everything from drone deliveries to, there's just tons of options here. Mm-hmm. As the kind of Wi-Fi and high definition kind of internet expands into the rural areas, I could strongly see some really amazing innovations following it.
I forget which one of those satellite companies that is now known as Ting around the area, but it is another one of those companies that are saying, "Hey, we've got a different way of doing it." What about and I know we've sort of pivoted off of telehealth, but access to it is a big portion of it, Caleb. SpaceX, I think the last 3 missions have put up maybe 15 satellites that, as I'm explained to it, and people try to keep things in small, short words for me to digest, ostensibly satellite Wi-Fi, satellite-fed internet service, wireless internet service, so that we don't need to wait for our local county government to create a slush fund that will have 3 or 4 6-figure bureaucrats operating a very slow internet system. But it came from the county, so it must be good.
Absolutely right, man. I'm a big fan of Elon Musk, and I really, really am very, very excited about this kind of space internet that he's got going on. I don't understand the underpinnings of it. I'm an economist. I'm not a tech guy, but I'm super excited about the implications of such a thing. I'm connected with, have acquaintances that are in the beta testing group that are saying that, they do get some interruptions because he doesn't have a full spread yet of satellites. They do see occasional interruptions, but they're seeing internet speeds that they never thought that they would see.
Really?
Out in their country Montana home, right?
I've had a wonderful day now already hearing that. That's so great to hear.
It is. I mean, they're getting, there was one guy I had briefly talked to over the internet, just kind of I heard about it and I asked him about it. He was like, it's great. Before the best I could get was 50 meg download speeds from our DSL out here. And, with the exception of some minor interruptions, I'm getting 130 down. And I'm just like, that's phenomenal. That's like city rates.
Yeah, it is. Absolutely.
I've been thinking about taking up online gaming now. I never did it before, but now I can do it, so I'm figuring I'd try it.
Well, it's interesting though. You see where the marketplace can move in, and we've watched municipal governments that seem to fight against cell phone towers for whatever reason. They find them offensive, and then they turn around at the next local board meeting and say, "But we've got a great idea for county-fed broadband that will run right to your house." I'm like, maybe that's why they didn't want the cell towers in the first place, because again,
the kickback.
But it also leaves the consumer in the driver's seat. And in circling now back to telehealth, it gives us that opportunity. If I live in Montana, it breaks up the city just in the time when all of a sudden we're told, don't live in cities, don't live close to each other anymore. And we're watching houses in what had been considered exurban, if not rural areas, selling in less than a day.
Absolutely. And this is actually one of the another piece of legislation that is up that we've been kind of keeping an eye on. It tries to handle the issue of cross-border licensure for medical personnel. So one of the main issues with healthcare costs, and there's a lot of them, but one of the main issues is that there's just not enough. There's not enough doctors. There's not enough nurses. Virginia doesn't have enough. And we've talked to doctors that, we want to offer, subsidies or special benefits to convince doctors to move here. I'm just like, that just seems like a really roundabout way of doing it. Why don't we just let doctors come here and operate, via the internet and not even have to move, right?
Does our favorite subject here, certificate of need, does that impact, can some well-meaning autocrat in Richmond decide, hold on a second here, you can't start up that internet telehealth service until you get permission from all the other internet telehealth services, just like we do with brick-and-mortar healthcare in Virginia, Caleb?
Well, I think that, it would be dumb of me to say no. Of course, somebody could probably come up with a really innovative way to screw with people in that manner. But generally speaking, having looked through a lot of this, the way that these things work, I actually think that telehealth is the natural enemy to COPN. It effectively undercuts the way that the COPN kind of monopolistic system operates, and it immediately starts dragging resources away from certificate holders, and it creates a space where, if you're somebody who has relied, if you're an organization that has relied on certificates to make your money, which there are, I mean, we've had hospitals we've had conversations with that have just flat out told us, if it weren't for certificate of need, we just wouldn't exist. That's how we make our money. And I was really amazing, kind of blown away by that. But it makes it so these people that are relying on those certificates don't have the flexibility to catch up any longer. So it actually traps them in their own monopoly. And I'm really excited as this expands. I'm really excited to see that happen.
Yeah, there's nothing more delicious than a big old steaming plate of irony, Caleb.
Yeah.
The last bit here for you, Caleb Taylor, Director of Policy with Tertium, Quids, and the Virginia Institute for Public Policy. In all of the remaining 4 or so minutes, talk about what the little brush past it at the beginning, where you saw, and especially in the health codes in Virginia, most everything was illegal unless you were given permission to do it. And I find that in the Commonwealth, that seems to be more and more the case. It's what gives the governor the power to declare unending executive order, emergency lockdowns, and go after businesses for their licenses. Are we at some point going to get to a point, or does this need to be a case where, legislatively we look at this? Because, I remember a bill that gave farmers permission to sell the produce that they made at their farm. And I'm thinking, hold it, we needed Virginia to do this, and it all seems like it's leftover King's Grant kind of common law from when we were a British colony.
I wouldn't say that it's that old. I think that probably there was some of that going on, but realistically speaking, I think the vast majority of this is recent. I would say in the last probably 80 to 90 years. And this really is specific to healthcare law. I mean, there's definitely circumstances like this throughout the code, but it is really rife in the healthcare law. It is written from this kind of rhetorical standpoint where they'll say something along the lines of, "You may now do this as of this date," which means that you could not do that before, even though it was not written in the code specifically. And anything that is not that, if say you may offer, if you're a doctor outside in Maryland, you may now offer services to patients in Northern Virginia. Okay, so what kept them from doing that before?
Exactly.
In that you might say licensure requirements, but just because you're licensed in the state, does that necessarily preclude you from operating across the border? I don't think it does in my mind. I can't imagine that it would. It just means that, hey, you can show this license to people, and this license means, yes, I'm an actual doctor. I'm not just some Fruit Loop that just got out of jail who's pretending. So we run into this kind of "you may now do this" language over and over and over again in healthcare code, and instead of handling, and it was really funny. I was having a conversation with a bunch of different stakeholders, and there were some lobbyists in the call, and I was having this conversation with them. And they said, well, we shouldn't really allow people to do that, or we don't want people to think that they can do anything.
Right.
And I'm just like, yes, we do. Like, that's how a free country works. If you have something that you specifically think is dangerous, great, let's talk about that, and then let's talk about restricting that. But if,
or at very least establish what the penalties are for doing that to someone. If you find something is illegal or you shouldn't do it to someone else, just establish what the punishments are, once you've been proven in a courtroom to have done it. But yeah, I think we've gotten to a place where, this Mother May I society is really, I think has left us behind the eight ball. You see where we rank. We're 48th, Caleb, in vaccine distribution, just over 25%. We're throwing away COVID-19 vaccine. And we're not even going to debate whether vaccine, this, that, or the other thing. But, the Commonwealth of Virginia, run by a doctor, under executive emergency order, is next to last in the nation in distributing a vaccine. I think it's all the analogy you need for our health care problems.
Well, this is the really important thing in the difficulty with this kind of technocratic idea that, being run by a doctor will make your healthcare system better, right?
Yeah.
The issue is that doctors are really good at being doctors, okay? I am sure that Governor Northam and the other doctors who are in the legislature, in their practices, were caring and worked really, really hard for their patients, and their patients did well. I am sure that that's the case, just kind of based on a general idea of medical knowledge and understanding in the United States. That does not make them economists. You cannot say, well, he's a doctor, therefore he must understand distribution systems. No, that doesn't make any sense at all.
Quite the opposite, more likely.
Yeah, so it's this is kind of just one of those things. Like it's okay to trust professionals. It's okay to trust experts in the situation that they're an expert in.
Yeah, that's true.
And I
Caleb,
think that's one of the major problems that we have in discussing things in our society, is that we misplace kind of expertise.
Right. Yeah, it's a doctor doesn't always mean the same thing. Caleb, thank you so much for your time. Thank you so much for everything that the whole organization does here at the Virginia Institute for Public Policy, including putting this show together. And you have a wonderful weekend, sir.
You as well. Thank you very much.
And for you, thank you for tuning in this week to Freedom and Prosperity Radio. For all of us here at the Virginia Institute, until next week, my name is Joe Thomas. So long, and thanks for all the fish.